While you're getting ready, I'll just make two comments. The first is that we've made a lot of recommendations, as we do with the National Audit Projects, and those recommendations are stratified by national, institutional and individual. A lot of them are reiterations of stuff that's already out there, and that's intentional, so that the report is a complete project. But I think they do add to supplement to those, and in many cases make new recommendations which were hitherto not made, and I hope it takes things forward. The whole point of this is to improve consistency, reliability and overall care for patients. And the last thing I'd say is that, what was the last thing I'd say probably, is that just to thank the BJA. So there will be 5 papers appearing. I think 2 have appeared today and another 3 will appear in the next probably 24 hours. So 5 papers that will appear in the BJA. I think there are going to be 5 editorials to go with those 5 papers, and those will be published in the July edition of the BJA. We hope there will also be a paper in clinical and experimental allergy. Regarding the BJA, very specifically, Hugh Hemmings, the editor-in-chief, and the willing, able and very speedy reviewers have all been very helpful in ensuring we got the project onto the BJA, which will put it onto the international scene in a bigger way as well. So now we have time. We have 20 minutes and no seconds for questions and answers. So we'll go, and I think, although we've got the panel talking about the Big Four and special situations, I think we'll go for questions on any topic for this last 20 minutes. So we'll start over there, I think. And then there's a good question over here.
Thank you for a really good day. My name's Paul Syce. I'm an anaesthetist in Plymouth. And I, along with Sarah Ford, do the anaesthetic allergy follow-up along with the immunologists. And there's just a couple of things I've heard this afternoon that I would like some advice on that have troubled me. In particular, this thing about advice for patients after they have testing and what they should avoid in the future. Now, we've, over the years, seen a lot of teicoplanin problems, but actually I think following up anaesthetic anaphylaxis can be really complicated. And a sort of typical Plymouth orthopaedic case is someone who's gone to sleep in an anaesthetic room, has a muscle relaxant, because the Fuller figure in Plymouth is very popular. They come into theatre, within 5 minutes. They are getting some teicoplanin. Hopefully separately, they're getting some gentamicin. They're having a urinary catheter with latex. They're getting Instilogel, which contains chlorhexidine, and they have a cardiac arrest. And we've heard that often with follow-up there's more than one positive agent. We know that the sensitivity and specificity of skin testing is not 100%, so you can see false positives, but you can also see negatives testing that may be for culprit drugs, whereas a non-IgE mediated mechanism. So we've then got this problem of when we're, investigating them and what we, and if we've maybe have more than...
I'm going to ask you to speed up and get to the end of the question. All right?
So what I'm saying... Well, no, what I'm saying is I don't think it's always possible to nail down to one thing, and I think if you're going to start challenging people to gentamicin and teicoplanin when they've had a cardiac arrest, it's downright dangerous. And sometimes I think you have to accept that you're going to have to avoid more than one agent.
Okay, let's put that to the panel. Let's put that to the panel.
Latex chlorhexidine.
And I'll start with that one. So we do generally challenge patients in as safe an environment as possible in order to try and essentially, if possible, have a single culprit. We can't always have that, and where we do have significant positive tests, we may have to advise avoidance of more than one agent, but we certainly try not to advise avoidance of multiple agents.
We try not as well, but I think sometimes you just cannot nail it down to what. I'd just love to know.
Let's listen to the panel.
Okay, so I would say that it's not always possible, but in the majority of cases it is possible, and the important aspect of perhaps what you haven't said is that you have to correlate the timing of administration with symptoms, and you've seen that actually we've got a lot of information about the onset of the reaction after each potential culprit. After NAP6, I'm hoping we're going to now start administering antibiotics before induction of anaesthesia, so that will clear it up even more. If we can persuade a few people to think about Folcadine, we might make some further changes. But the clinical correlation is absolutely key, and then we've got to narrow this down to just a few culprits and then undertake challenges. But you're right, it isn't always possible, but in the majority of the cases, I think it is possible.
Okay, next question I think was over here.
I'm an anaesthetist involved in allergy work up in Southampton. I have two questions about test dosing for antibiotics. The first is, I know that you have recommended that we avoid test dosing for antibiotics. But of course, that's not the approach we use in doing IV challenges. We would give very tiny doses, wait and see what happens, give another slightly less tiny dose, and give a full dose over a space of about half an hour. Now, I accept that half an hour dosing is probably not optimal for giving prophylactic antibiotics, but I would suggest that giving it or recommending a sensible test dose is better than suggesting that we avoid it altogether, having precipitated a fantastic anaphylaxis in clinic whilst
Right, I'm going to ask
IV
Nigel.
challenging for ticaplanin.
I'm going to ask Nigel to take that one on.
The consensus of the panel is that there is no place for what anaesthetists generally understand to be a test dose. And we were unanimous in that. There is no place for test dosing for two reasons. Firstly, the doses that are used for test dosing are probably 1,000 times greater than you'd use for a challenge. And secondly, as our data demonstrate, we didn't have time to show those data today, but they're in the report, anaesthetists don't wait long enough after their test dose for obvious reasons, because we're under pressure to get everyone. But the most important reason is the former, and that is dosing. There is no commonality between test dosing in inverted commas on the one hand and provocation testing or challenge testing on the other hand. They're two different animals, and there is no place for test dosing.
Okay.
Next question, we've got one gentleman in the middle. And who would like to ask a question after that? So it's quite a few questions, so if we keep the questions reasonably brief, and we'll get through a fair number of questions. Thank you.
A brief question for Shoaib. You mentioned that a large, was it, what fraction of ticaplanin reactions were in patients with a declared penicillin allergy? Now, is that coincidence, or is there something to do with the beta-lactam? Are they totally discrete molecular entities, or is that just a coincidence?
Yeah, okay, so I should say I've been grappling with this a little bit, and I thought I'd come up with the answer, but I can't quite remember what the answer was.
It's been a long day.
But the molecular structure is completely different. So there's no reason to assume that if you have a penicillin allergy label, you'd be more likely to be allergic to ticaplanin. The other thing to note, of course, is that the majority of these 20 cases with a label of penicillin allergy will not be allergic to penicillin. So perhaps only 2 of them might be allergic. That still leaves 18 with simply a label, and they've gone on and developed an anaphylactic reaction. So I think we're slightly extrapolating, and I really don't think that there's a relationship. But the bottom line is that we are giving, because ticaplanin is very allergenic. We are administering ticaplanin to a lot more people simply because they have a label. And there were a very large proportion of people with a label of penicillin allergy, most of whom obviously weren't. And I would just reiterate the fact that if you develop an adverse reaction to any antibiotic, write down the clinical details, write down exactly which drug it was, and that will give you the opportunity, it will give all anaesthetists the opportunity to decide whether they're willing to take the risk to administer it or not. And the majority of cases, you would be willing to take the risk, I'm sure.
Okay, keep your hands up. Next question. No questions about blood pressure of 50 millimetres of mercury and starting CPR. I'm interested in no questions about that. Where's the microphone gone? Oh, lovely. Caroline.
Hi there. So, question for Nigel. Hi, I'm former midwife, but I'm here as a patient, having had anaphylaxis. I was intubated for asthma, and it was to cystaticuria, and basically I was confirmed with, future skin prick tests, intradermal tests, IgE level tests, etc. I'm just wondering, when you were talking with regards to atracurium, etc., and saying that cystaticuria was probably less likely, but I also noticed that it was used far less so. So I'm just wondering whether there is a sort of correlation in that sense, or do the figures sort of prove that cystaticuria is a safer NMPA? Or just wondered from that side of things.
Thanks very much for that perceptive comment, Caroline, and thanks for being here today as a patient. We appreciate it. My comments about cystaticuria being cleaner really related to non-allergic anaphylaxis. It's less likely to cause non-specific mast cell degranulation, non-specific histamine release, and patients going red and maybe developing some bronchospasm than atracurium on its own, than atracurium. When it comes to allergic anaphylaxis, you're absolutely right. Cystaticuria is used so infrequently that we can't really make a like-for-like comparison between the two. We can't. I don't think we can say that one is safer than the other. My personal view is that, given the choice in someone with asthma, I would prefer to choose a drug that is known from animal studies and human studies to cause less non-specific histamine release than another drug. I think that's probably all one can say. Yeah.
Okay, we've got possession of the microphone up there.
It's a question regarding chlorhexidine testing. When you talk about chlorhexidine testing, do you mean pure chlorhexidine, or do you test it with the dyes that we commonly use in it?
So the chlorhexidine that's used for testing is a bit variable across the UK. Some of them are the pink-coloured chlorhexidine that's used. Some are the non-coloured chlorhexidine that's used. The Europeans are very keen to use non-coloured chlorhexidine for testing, but in the UK we do tend to use a variety of different chlorhexidines for testing. We don't necessarily see a lot of false positives, but that's just a feeling from clinical activity. It's more the concentration that we find is important for the different modalities of testing. So for skin prick testing, IDTs, making sure the dilutions are correct to not elicit a non-specific irritant reaction.
And Thomas, do the dyes themselves have any allergic propensity?
Not that I'm particularly aware of. I don't know if anyone else would like to comment on that.
Well, I just know that from an obstetric, anyone who does regional anaesthetics, you want a chlorhexidine with a dye in it to try and minimise any chance of it getting anywhere near the epidural or spinal space. So I would personally vote not to have any undyed chlorhexidine in the hospital, full stop. But that's just.
Okay, so I should just say that for skin testing, we shouldn't be using the dyed one because there are some allergens in the dye that could give a false positive. PEG.
How frequently might that occur?
Well, polyethylene glycol is in some of the chlorhexidines that are dyed, so I would definitely avoid it. Yeah.
Okay.
For skin
question down here, and then I think we're going to go over there. Can we get the microphone over there? There's a cluster of hands over there.
Okay.
And then we've got Louise, who'd like to ask a question in the middle.
Just a comment in relation to Nuala's talk about when she raised the question about latex. I'm down here.
Oh, sorry. I didn't have my glasses on.
So you can see that. So since the introduction of non-powdered latex gloves, there's been a massive reduction in latex allergy, and we hardly we see very little of it in allergy clinics now, and correspondingly it's becoming a very much less common, pretty rare in fact, to see latex allergy causing anaphylaxis in relation to anaesthesia. So it hasn't disappeared totally, but it's way down the list.
Yeah, I mean, I think, and that's what I've seen in my clinical practice. I mean, I think for quite a long time it was, we were all so vigilant, so concerned about it. I think there were a lot of people being mislabeled as latex allergy. And when you question them, they might have got a bit of a red rash a long time ago with washing up gloves or something. But I agree, I would absolutely share your view on that.
And apparently there were no cases of latex anaphylaxis.
In NAP6.
In NAP6.
In the UCOS survey that I mentioned, which looked at anaphylaxis in all pregnant patients, not just related to anaesthesia, there were no cases of latex anaphylaxis identified either.
Okay, we've got about 5 minutes left. 6 minutes. Let's go for 6 questions in 6 minutes. At the back.
This question is regarding Sugammadex use for anaphylaxis, rocuronium anaphylaxis. I'm just reading through, and from what I heard during the talks, if I'm right, there is no good evidence that it actually makes a difference in the treatment of anaphylaxis to rocuronium. However, there have been some recent reports. I think there was one from Japan, specifically for anaphylaxis to the Sugammadex.
You're going to run out your minute while you're asking the question, so I'm going to ask
rocuronium complex. So, what do you comment?
We've got the sense of the question. Thank you.
Yeah, I think I've got the sense of the question anyway. The case reports are one thing, individual case reports. Of course, they can just demonstrate the patient improved or not with Sugammadex, but there's no case control. The study I referred to, the more recent study, where there were case controls of a sort, demonstrated that Sugammadex was equally effective if the reaction was actually due to an antibiotic. Equally effective as if the reaction was due to rocuronium. That doesn't mean that it had no beneficial effect, of course. It's possible, just possible, that somehow Sugammadex is reducing the immune response or reducing the concentration of circulating mediators. Who knows? I doubt it, but it's just possible.
Okay.
Possibly a question for team. Half of the cases were excluded from the
I think
analysis.
you might want to start that again. I don't think we quite got the start of that.
Half of the cases were excluded for the severe anaphylaxis from the scrutiny. So is there any constant theme running from those cases which were not analyzed in terms of either causative agents or difference in the fatalities on those 250 cases which were not included?
Yeah, so about of the 600 cases we got reported, some of them were not admissible, didn't meet the inclusion criteria. That took us down to about 450, and then 200 were excluded for, again, another whole variety of reasons. That included that many were reviewed and they weren't anaphylaxis, others were grade 2, and a lot of them we didn't have enough information. So in our estimates of incidence, so because a lot of them we didn't have Part Bs, so we didn't know what the investigations were, so we couldn't conclude a great deal. So we've said that although the headline instance is 1 in 10,000 or 1 in 11,000, the upper estimate without confidence intervals is about 1 in 7,000, okay, which is again higher than previous studies. Good news is we're going to have drinks in about 4 minutes, so we'll be able to just carry on with the discussion. Chair in the middle.
10-second question, I promise. Patent blue dye. Any evidence for pre-treating with steroids or histamine blockers?
Very briefly, not that I could find.
Okay, Louise.
Another quick one. Spain have just brought out their perioperative management of anaphylaxis guidelines, in which they recommend methylene blue as a first-line treatment along with adrenaline. I just wondered if that's going to come to the UK anytime soon. First-line adrenaline, methylene blue, second-line steroid and antihistamine.
I'd love to see the evidence, yeah. Methylene blue has been around the block for shock so many times since I've been in practice.
But with really bad outcomes.
I'd love to see some convincing evidence. Yeah.
Another really quick one. Is there a place for trying to scale back the sort of ubiquitous use of chlorhexidine in the healthcare setting on the basis of the fact that we have so much allergy to it?
Risk-benefit.
So, I mean, there are some areas where you can do that. So the urological exposure can be literally got rid of overnight just by using non-chlorhexidine containing urological gels. The other areas are much more tricky because the evidence is really good for chlorhexidine, and the alternatives are either not as effective or ineffective.
It's fair to say that a lot of this stuff is covered in the chapters. They all start, what do we know already, what's NAP told us, and then a discussion afterwards. So although we've had you've had 5 minutes on chlorhexidine, but there's a 15 or 20 minute read of an excellent chapter by Thomas in the report. So although you've been here, it's still worth reading the report, I would hope. Where's the next question from?
Can I just ask, you're recommending that people should have their antibiotics prior to having their anaesthetic. Who on the panel would want to have a severe anaphylactic reaction prior to having the anaesthetic? Because personally, I would rather have it with somebody who's capable of dealing with it and under anaesthetic, where I'm likely to get less post-operative sequelae.
To be clear, we're not recommending that the antibiotics are separated from the anaesthetist. We're recommending that anaesthetists give antibiotics early.
Yeah. And we'd rather have it while you're awake rather than asleep.
Yeah.
I'd rather have my antibiotic first and potentially experience the anaphylaxis to it and not have to go through a large number of additional unnecessary investigations after the event.
Including drugs that make you very hypotensive, and to be able to tell the anaesthetist that I'm feeling a bit ropey.
I agree it's going to make testing a lot easier.
It makes, well...
But is the patient experience not going to be far worse?
It also allows you to undertake your anaesthetic in the knowledge that you know exactly, I mean, if this was an urgent surgery, you would know exactly what caused the anaphylaxis, and you wouldn't be worried about a whole host of other drugs. So it will make life a lot easier for the anaesthetist.
I feel slightly overwhelmed by the number of recommendations and the things I've got to reflect on in my practice. But of the things that I've read, I think that's one thing that I'm specifically going to do. As soon as the patient gets in, cannula, give the antibiotics. That's one of my personal top 5 things I want to change from NAP5. And I think that you'll be much better off. I mean, and it removes the uncertainty about whether to proceed, which I think is often an issue. That's just my personal view.
It's the number 1 recommendation.
I'm not falling for that. So we've got the last
I've got a question that's going to ask Nuala to sort of expand
Sorry,
that.
quiet, just so we can hear.
I think I've got a question that's going to ask Nuala to sort of expand that answer a little bit further, because in Norfolk we've changed our antibiotic prophylaxis for cesarean.
Sorry, can you speak up?
About 3 times. We're now in the daft situation where anyone who comes up and says that they're penicillin allergic, we're now giving them 3 antibiotics, one of which is ticaplanin.
Yeah.
It just doesn't make any sense.
What's wrong with clindamycin? I mean, I think the whole antibiotics and caesarean section issue is going to come up for discussion again in the next few years. So back in 2011, NICE changed their recommendations so that instead of giving antibiotics after the baby is born, we now give them before the baby's been born, as in every other area of surgery. But there's a massive amount of discussion going on at the moment about the effect on the neonatal microbiome. And there's an association, of course, we don't know if it's causative, between changing neonatal flora and perhaps asthma, bowel disease. So I think the whole antibiotic issue and caesarean section topic is going to come to the fore again. In terms of what agent you would use, I think NICE and most agents recommend what is, because it's you're trying to cover many flora, and you need to speak to your micros to see what you need to cover. I can't believe that Norfolk and Norwich is that contaminated that you need 3 agents. I can't give you definitive advice. I personally think that 3 agents sounds a bit over the top, but I'm not a microbiologist.
I wish we'd had a microbiologist on the NAP6 panel, actually, in retrospect, because I think the fact when some of the graphs in the antibiotic chapter, when you look at those, the range of drugs that are given in the same specialty and the variety of different drugs that are given doesn't make sense. 9 or 10 different drugs being given commonly in one specialty doesn't make sense. We must wrap it up there. Can I ask you to thank the panel first? I'm not going to hold you back for more than a minute, just to say thank you very much. And my last comment would be that this is a massive collaborative project done by UK Anaesthesia, UK Allergy and UK Immunology, and I think everybody should be proud of what people in their hospitals have done to bring this project to fruition. So thank you very much.
Just one comment. I'd like to second those thanks and that appreciation. We're going to get together over the next few weeks a slide set such that if you want to run meetings in your hospital, that will facilitate that happening. So please watch the website.
And there's a trick.